This podcast is sponsored by the University of Hertfordshire. So the University of Hertfordshire offers a post-registration MSc in advanced paramedic practice. This is designed for flexible part-time study with some online modules available as well. So students can choose from 2 specialist pathways, that's of primary and urgent care, or indeed emergency and critical care. Additionally, the programme includes modules in allied health areas such as leadership, coaching and independent prescribing. The course is taught by expert, research-active staff with national and international profiles, ensuring students receive cutting-edge knowledge and practices. So innovative teaching methods include online resources, virtual reality and advanced simulation kits enhancing the learning experience. So the staff have over 25 years of heritage and the programme has a strong reputation and a proven track record of success. Graduates enjoy excellent career prospects supported by the university's robust professional network and industry connections. So opportunities for further academic advancement are available through the Masters by Research and PhD. So this course is open to anyone who's wanting to advance their careers and contribute to the field of paramedic science. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
So welcome back to the Pre-Hospital Care podcast with me, Lisa Burrell, and it's my absolute pleasure to be joined today by Dr. Maren Ranhoff. Maren is a consultant physician in neurology at Oslo University Hospital and associate professor even of pre-hospital medicine. She's the head of the Prehospital Acute Brain Programme, which is an important programme at Oslo University Hospital that we're going to be hearing more about in this podcast. Maren and her team have been doing some absolutely fascinating work, and it's frankly just hugely important for the whole medical community in prehospital care, looking at the prehospital link in the chain for stroke care, all the way really from dispatch, all the way through assessment at the scene, triage and communicating the right handover. It's just wonderful work, and we're going to hear about it in this podcast here today. So welcome to the podcast, Maren, and thank you for taking the time to talk to me today.
Thank you so much for inviting me. It's such a pleasure. And thank you for your kind introduction. And I just had to add that the most important affiliation that I have is that I used to be a trained EMT, and I'm very proud of that. And on the way with research and education, I ended up as a neurologist. So today I present myself as an ambulance neurologist, and I'm very proud of that.
Which is an extremely extraordinary, unique position to be in, which is why it's really special to have the opportunity to talk to you and hear your amazing insight, actually, Maren. So can we start by maybe going right back to the beginning of your journey with this, and where did it all start? Obviously, you were working as an EMT, but what were your motivations and what sort of taken you to want to explore this?
I was lucky to do medical school in the northern Norway, the northernmost university in the world, actually in Tromsø, which is above the polar circle. And during my study, I was lucky to get a summer job in the ambulance service, and I did some coursing to get the EMT authorization, and then I did 4 years working in the ambulance service in weekends and in holidays up there in the far north. And as you can imagine, there are vast distances. There are sparsely populated. During the winter time, there are 2 months of complete darkness. And roads are not European capital standards. And you can be in transportation with critical ill patients up to 2 to 3 hours to go to the university hospital. And I believe still today that a lot of my clinical skill, I got the experience from that time in the ambulance service, because to be able to be with critical ill patients over that long time and to actually observe critical illness developing was quite an experience. But it also, in a way, got me a bit. I will see that the experience was paving the way for me, what I wanted to work with later in life, and what I saw was that there was a miscommunication and we didn't really have a joint expectation of what the patient would be like when we arrived at the hospital. And in several different cases, I felt that we were speeding on icy roads in the dark hours and more or less putting our own lives into stake to save these patients. And then we arrived at the hospital hours later, and the physician on call would maybe be in a different part of the hospital. We're not prepared at all, and all this time that we'd gained to go there, to go with the blue lights and to the above the speed limits and everything was more or less a waste, and it felt so. I was really devastated about that, and I wanted to work with the system. How can we get streamlined patient care, and how can we, in a way, move competence from hospitals and into the pre-hospital field? Because if you want to change and if you want to improve healthcare in the acute medical setting, then you need to start in the pre-hospital field. And then it was more or less by chance that I ended up with neurology. But diseases that affect the brain and the nervous system are also the most critical ones. So it's, yeah, that's more or less the background of how I ended up with acute stroke care.
Well, it may have been a bit by chance, but it's certainly a passion of yours and a passion that we both share. And I think you probably couldn't have picked a more important body organ to be trying to support and save. I mean, I've been a paramedic a while, probably longer than I'd want to admit. And it's amazing that we both sort of started our journey maybe with a very similar motivation and similar experience, really difficult. I remember in the UK, when stroke was not even really seen as an emergency, certainly amongst ambulance clinicians, and we used to sort of see it as a sad inevitability of aging. We used to be very accepting of it, and just to think how much culture really has changed around this is incredible. We now have, this sort of concept, time is brain, and think fast, and it's really amazing to see how stuff has developed. Even here, in 2001, the Department of Health recognised that there was this need for improving stroke care through the National Service Framework for Older People. And that led to a really great public education campaign, which has really transformed even recognition amongst the public for stroke. It's improved assessment of TIAs, being referred more urgently, stroke calls being categorised at the point of the 999 call as a high priority. Ambulance clinicians treating it with more urgency, very similar to, I remember walking into patients' living rooms and seeing them suffering symptoms of brain cell death. And I would stand there and have a conversation with them, thinking all I could offer them was sadly some reassurance for something very difficult that was happening for them.
Yeah.
And we would talk about the pictures on their mantelpiece, and we'd gather their clothes and we'd slowly get them into the ambulance. But if we went to somebody who was having crushing chest pain with ECG changes, we'd get our skates on because they had a clot in a vital organ of their body, and we'd get going. But we just didn't have that perspective for stroke certainly when I started, and it is so inspiring to see the work you're doing and seeing how things are changing. And we've certainly demonstrated in the UK that stroke patients who receive that organised inpatient care in stroke units do a lot better. And the assessment of the ambulance clinicians to get them on that right pathway, and just all of the detail that you're talking about and working on is absolutely instrumental, in my opinion, to getting people to the place where they're going to be, given the best chance, really. So it's really, really great. Can you tell us about the Prehospital Acute Brain Programme? Just to give us a little bit of context around that. Who does it involve? What are your key work streams, and what is it that you're trying to do in your team?
Yeah, the Prehospital Acute Brain Programme started out with actually my PhD project back in 2012, and we wanted to look onto the MSU model, the Mobile Stroke Unit model. There were one model at the time from southern Germany. And the concept of mobile stroke is to implement acute stroke diagnostics and treatment into the pre-hospital system. But in this pilot models from Germany, There were neurologists from hospitals staffing them, and they had neuroradiologists and all these in-hospital specialities. And for the Norwegian pre-hospital system, this wouldn't work. We don't have enough neurologists to staff our hospitals, so it would be not possible to even think about putting neurologists in a pre-hospital service. And I've never been very fond of the idea that we should send out stroke ambulances or orthopedic ambulances or pediatric ambulances. We need a pre-hospital service that can care for all patients. So we wanted to make a new model and test out if we took this mobile CT scanner, but we staffed the ambulance with the same crew as in the air ambulance. So in our Norwegian mobile stroke unit, we had a paramedic as a pilot, and we had a paramedic as a paramedic nurse, and we had a anesthesiologist trained for pre-hospital care. And my PhD was focusing on the assessment of stroke in this model and whether if it was possible for this crew of 3 to do the full diagnostic workup with the CT scan, the interpretation of scans, and to more or less make up the diagnostic decision whether to give thrombolytics or not. And after completing this pilot study, then we had really good results. Actually, the anesthesiologists trained to interpret scans were better than the stroke team at the local hospital compared to neuroradiologists. So we wanted to go further, and then we started a clinical study with pre-hospital thrombolysis. And these 2 projects, we learned a lot about the chain of stroke survival in the pre-hospital service and the knowledge gaps that were there. And I think what really surprised us was the heterogeneity of stroke patients. Most stroke patients do not have a simple hemiparesis with no contraindication, calling dispatch center on time for thrombolytics. Most stroke patients have subtle symptoms. They have a lot of contraindications. They don't know when the stroke started, and so on. So the heterogeneity of the population learned us that if we wanted to utilize this CT scanner, then we need to look at the whole chain of stroke survival. And it starts at dispatch. So we need to have research programs, projects that focuses on identification in dispatch, new technologies to improve the tools for dispatch, recognition of stroke, and we need a communication platform that goes all the way from dispatch via the ambulance service and into the ERs. And we believe that if we look at the whole chain of stroke survival in the pre-hospital field, and when we realize that there are gaps of knowledge, that are new areas of focus that we should look into, then we will try to make a new project. So today we actually have a whole program and we have 9 PhD candidates and we are 3 senior scientists. And we have projects in dispatch looking for AI tools. We have a new planned project for video in dispatch, video that will be directly then transferred to the ambulance. And ambulance, we have also hopes for video consultations in the ambulance. And we have projects looking at sex differences in pre-hospital stroke care, vertigo patients. We have projects that are exploring how can we train paramedics in a more efficient way. So we have developed a full gamification platform with VR gamification of clinical assessment. And with the big project that we have conducted over the past years, the ParaNASPP study, we have a full digital platform for operative use in the ambulance service for clinical assessment of stroke patients. So yeah, that's more or less the program today. And more projects are coming up over the next years as well.
I mean, listening to you, it is just so innovative, and it is so exciting because it really emphasizes the impact of, you know, those early minutes, that early time. That's a really precious time that we have a privilege to make a difference to people in that time. And it's so exciting to see all the different directions that are opening up through this work that you're doing, and the amazing team that you have, the academic funding, and the ability to really get to grips with some of these things. I mean, and to take it right back to the point of call. I think it's just really, really very special. And I work in education. I'm absolutely fascinated by the journey in education that you've had with the paramedics. As a paramedic myself, I have to say it is hugely inspiring to hear your whole team investing in educating the paramedics, because that is crucial, isn't it, to make any of these things really work for like the subtleties of the patients that you're talking about.
I think paramedic training is the most important key of efficient stroke care, because patients with stroke, there are many of them, and we cannot have like hyper specialized physicians going out to see all these suspected stroke patients. We need to look for more symptoms than only the large vessel occlusion symptoms, because I really believe that all stroke symptoms deserves to get identified in the first hours after their symptom onset. And we need to believe in developing new ways to educate, and not to narrow down that this is too complicated, or then we need to rather turn around and look, how can we make this complicated diagnostic assessment available in a new way of training. So yeah, it's all about competence. I believe that the key for efficient stroke care is about transferring competence into the pre-hospital field.
100%. I completely agree with you. And I think if we're ever going to find tools that are more effective than the tools we have now, that has to be supported by proper education. Otherwise, paramedics will just use the tools for the patients that they already recognise with the experience and instincts that they already have. They're not starting to see, like you say, the new arterial territories or things that they haven't been used to assessing before. I know that when I was trained as a paramedic, it was very much maybe this is a bit unfair, but it was very much the understood culture at the time that strokes present with face, arm or speech weakness, and that is a stroke. And it was really eye-opening to start to educate paramedics around there are other arteries, and there are other areas in your brain, of course. And look at everything that your body does, and your brain is looking after all of that. There's other arterial territories that we're just missing. We've missed for such a long time. We've tried different stroke assessment tools that pick up those posterior circulation infarcts, or the slightly smaller, more subtle ones, or tried to rule out for mimics. But in my opinion, some of those tools haven't been taken up because they haven't had adequate education support for the paramedics to really put into practice. And like you say, there's absolutely no reason that this is too complex for us to understand. In fact, it can be made really simple, and your team are doing this really effectively with an app, which is just fantastic.
Of course, I'm dreaming about a biomarker that says stroke, no stroke, or bleed or clot. But at the end of the day, I do believe that we are underestimating the power of utilizing the brains of the people working in pre-hospital healthcare, and we really need to start to invest more into research and development in how to train and how to make tools that can transfer competence. And competence is a key, but I also believe in streamlining communication. Because today we are doing the same examinations, we're questioning the same questions up and again, and we should also look into streamlining this and to use more digital tools, I think, for communication, and it will be time saving, definitely.
Yeah, I mean, if I think back to that example I used at the beginning about how we used to have urgency around cardiac thromboembolic problems, heart attacks. There we go. And I compare that to stroke. I mean, paramedics for a long time have been able to localize lesions in the heart, not in the brain. And there is no reason why reading an ECG and localizing an arterial territory in an ECG is any less complex. We've learned to do that, and we can recognize these arterial territories in the brain. We can recognize these symptoms, and we can certainly train our paramedics to pinpoint what's happening in our patients to a higher standard. We've educated the public to be able to recognize the FAST campaign, think fast. That's the level of the layman. Paramedics can go a lot beyond that now. So it's really, really exciting. And you've alluded to the work you're doing through artificial intelligence to support that. Can you just tell us a little bit more about how that works?
We were just in the starting phase, but we've been looking on dispatch, and I think that if we have like a active listener, a computer active listening to the conversations, then we can. At the moment, we're going through the audio logs for 950 known stroke patients that were contacting the dispatch center in Oslo, and we're going through in detail all the different words that we used and how they are trying to explain stroke symptoms. And after doing a qualitative analysis of this audio logs, then we hope that we can start active learning of a machine that can do like active listening to the conversation. I don't believe in AI to do the whole workup in dispatch, because I think that people in a crisis really need to talk to another human being. And I think there are still a lot of different dialects, different needs in a conversation that cannot be replaced by AI. But maybe we can have an active listening to the conversation, and then some red flags when we identify different ways of wording that we see as a pattern in patients with acute stroke. And we are also looking into this dispatch with different angles. We're looking into the vertigo patients. Do they communicate symptoms in a different way? And also for sex differences, that I really believe that we have sex differences in how we communicate acute illness. Of course, we are communicating differently in the society, so definitely there will be sex differences in how we communicate also acute illness. Yeah,
and just while we're talking about the sort of innovative ways that you're using technology, you have this e-stroke concept, is that right? What's that all about? Can you tell us about that?
Yeah, that started with I really wanted an higher level of competence in assessment of clinical symptoms in the ambulance service. So I looked at different pre-hospital scales, and they're all focusing on large vessel occlusions. And then I looked at trauma care, and a Glasgow Coma scale is internationally used by physicians, by paramedics, and I asked my paramedic colleagues that wouldn't it be strange if you were using a different scale for consciousness level than the trauma physician in the trauma team? And everybody I talked to were like, yeah, that wouldn't work. And said, so why are we doing this in stroke care? Why are we using different scales in the pre-hospital field compared to the scale used by stroke physicians? And then we started to look at NIHSS, which is the most validated, the only stroke scale used in hospital stroke research and in hospital stroke care in the world. And why not implement NIHSS in the ambulance service? So we did some pilot studies, and then we saw that there are some challenges using the traditional NIHSS. The wording is quite, it's not really functional for an acute setting. And I used to, in Norwegian, I usually say that it's made by neurologists for neurologists and not for acute care. So we needed to put it into a new concept, and we took all the wording into pictograms, and we developed an application. Because as a young stroke physician, one of my real headaches in the stroke team was to remember the score of 2 and the score of 4 and the score of 1, and then put them together and calculate the total score. And up to now, I've never completed that correctly because all the stress in that team and to remember all these scores and so on. So I wanted a calculator, and I wanted a tool that could instruct the paramedics in how to do a correct NIHSS, and I wanted it to be in a 20th century format. So we made this application, and it has then pictograms. It calculates the score. We put in the most important clinical factors for stroke assessment with anticoagulant drug use, time of symptom onset, and vitals for blood pressure, pulse, and blood glucose. And at the end, and what I really missed in my work as a stroke physician in the communication with the ambulance service with the suspected stroke, is the structured report. Because most of these reports are, yeah, this is ambulance 234, we have a female, she has a paralysis, and it goes on. And I really wanted to structure this report. So at the end of the application, there is a structured way of reporting. And by sending this digitally to the stroke physician, you have a template that you can start your discussion based on. So that's more or less, it's really easy. And then we trained 250 paramedics in the Oslo region. And during 2 years, we completed the randomized control trial, including 800 patients. And this was the ParaNASPP trial published in Lancet Neurology last fall. Yeah.
And indeed, I would really encourage everyone listening to this podcast to go and read that trial, the ParaNASPP, Paramedic Norwegian Acute Stroke Prehospital Project, ParaNASPP, NASPP. In case anyone wants to go and look it up, do go and read that trial, because this has been such a huge piece of work as part of all of the work that you're doing, hasn't it? And what did you find through doing that trial? What were the findings, and where is it taking you now?
We found what I hoped for with the implementing NIHSS and training paramedics in NIHSS compared to standard care, which would be fast scale in Norway. We will find more patients with subtle symptoms. We will find the patients that has less symptoms than the fast positive symptoms. And what really surprised us was that when the paramedics used the e-stroke application and the NIHSS, they saved time in the in-hospital diagnostic workup. So we had a shorter door to CT time and door to treatment time in the group. Unfortunately, we could not conclude on the pre-hospital time in the study due to the pandemic, because the study was conducted during the pandemic, and we had a 5-minute increase of pre-hospital on-scene time due to all these infectious disease protocols that were implemented. But the main finding is that you find patients with subtle symptoms, and that was really the goal of the whole project at the beginning. And today, e-stroke with the competence program teaching course for paramedics and the application tool is implemented in several health regions in Norway. So
that's amazing. And how did you find the paramedics getting to grips with the NIHSS? Did you find that was easy for them, or did you find they struggled with that, or what was your experience of that? Yeah.
We also did a qualitative study. You can find that one in European Journal of Neurology published, and the paramedics found the NIHSS with the application easy to use. They spend approximately 3 minutes completing the whole scale, and they really experienced that the established a common language with the stroke physicians. And we also interviewed stroke physicians that were involved in the project, and we got the same result. They had a stronger belief in, or the trust in the paramedic clinical assessment was much higher, and they felt that they were establishing a common language in assessment of stroke patients. So yeah,
this is amazing.
It's easy, but it's nice to get these results, definitely. Yeah.
Maybe it seems easy, but hugely impactful. Amazing potential difference for patients. It's incredible. And this, as you've been telling us about, has led to some more work in females. So we've had ParaNASPP, now it's FemNASPP, is that right? And VertigoNASPP, and these projects are now allowing you to look into the specifics of the patient population in a bit more detail. Have you made progress with those pieces of work?
We don't have results yet, but the goal is that we will have an e-stroke second edition, and then you will have a much more complex algorithm. So if you put in a female of 35 years old, then you will have different questions adding to the NIHSS than if you have a male of 85 years old, for example. And we also hope that we will get results that we can add some extra specific questions or extra specific examinations for vertigo patients. I really believe that is the greatest challenge for triage for the next years to come. Everyone talks about LVO triage, the large vessel occlusion triage, but as a stroke physician myself, I find that the vertigo patients, that's the real burden of patients and the really tricky clinical assessment patients, that we need some more pre-hospital tools to select the right ones for acute stroke care.
Which I guess leads us on to, like, where do you see all of this going? What are the future directions that you're excited about? Where could this take our patients for the future?
I do at the main idea of the whole project is to increase focus on pre-hospital competence, and that pre-hospital competence lies in the paramedics. It's not in pre-hospital physicians. It's not in advanced tools like CT scanners or so on. It's about clinical assessment and to really establish that. And at the national level, we need quality indicators for pre-hospital care. At the moment, we have very well-established quality indicators for in-hospital care for all acute diagnosis and for cancer, but there are no pre-hospital quality indicators. And for these diagnoses that we talked about today of cardiac arrest, myocardial infarction, and stroke, these populations are incredibly resource demanding for pre-hospital services. And also the prognostic, the value of good prognosis lies in early identification. So then to not have a system of quality indicators that really measures the patients going through the pre-hospital system, and then you can actually get a quantitative image of the resources put into these patients so that you can get the health authorities to understand that they need to invest in this part of healthcare. I truly believe is one of the challenges or the goals for development for the next years to come. So I'm hoping that the implementation of e-stroke would enable us to develop then pre-hospital quality national indicators for stroke care in Norway, and that we will have a pre-hospital stroke registry that is national. And then I'm hoping for an international collaboration. Myself, I will go to Melbourne, Australia, to the Australian Stroke Alliance for 6 months and a research fellowship from November. and really hope to get some collaboration with the Australians. And if there are listeners out there that are interested in pre-hospital stroke care, please just send me a mail, and please just share my contact information, Lisa, because we need to get everyone together to do some great work for the future, I think.
Yeah, the landscape for this is transforming, isn't it? And it's so exciting to hear about these programs, these little pockets of work that are going on around the place that are so hugely impactful. And if we could bring together concepts, it would be amazing. It would be so powerful. And working with the paramedics moving forward, education, do you see yourself still using technology to do that? Virtual reality, gaming? What do you think will be the future with working with the paramedics and moving their development forward for this?
I think for teaching, I think definitely the virtual reality in clinical assessment to train in a virtual reality is valuable. For patient care, I think we need more scanners out in the pre-hospital service. I think it depends on the area. In areas with vast distances, I believe in pre-hospital scanners in maybe local healthcare centers. In urban areas, mobile stroke units have proven both efficient and cost beneficial. I think to really develop this as a system that will be implementable, then we need paramedics to run these models. So in a project in the mountain area of southern Norway, we have a pre-hospital CT scanner in a healthcare facility, and paramedics are fully running that CT scanner, and via telemedicine, they will start thrombolytic treatment on site before transportation to hospital. So these kind of models, when you are both training your local paramedics in assessment of clinical stroke care, and then you are selecting the right patients for a pre-hospital scanner, or pre-hospital in the future, maybe a biomarker compared to a scanner, then I think in 10 years from now, thrombolytic treatment for stroke should be mainly assessed in the pre-hospital service by paramedics.
It's amazing, and the potential even outside of stroke for acute brain injuries is unbelievable. This is such a huge piece of work, and I suppose I'm left now thinking about how this maybe links with other pathways that are being worked on for stroke care. Particularly, I'm thinking about thrombectomy, but any of the pathways in development. Could this work link in with that? How do you see that all coming together?
Yeah, definitely. I think for thrombectomies, we are even more dependable on streamlined pre-hospital assessment, and I think there has been a lot of research on the clinical scale to identify the right patients. But if we compare, if we put both clinical assessment and a pre-hospital scanner or a pre-hospital biomarker to select the LVO patients or the large vessel occlusion patients for a thrombectomy, then we can really, in a way, you utilize the resources in a better manner than today, when the question is drip or ship or going bypass local hospitals. Then we can have much more correct selection and patients. We have been actually thinking about also CT angio in the pre-hospital setting. I think with new software, new machines, it's absolutely possible. We should. I think that thrombectomy is highly specialized, so that would never be a remote service. But the the task to select these patients will definitely be a pre-hospital issue for the future. And if we can both increase competence and then get tools for diagnostic workup, maybe thrombectomy selection will be also a pre-hospital matter in a few years to come. Yeah, and there are so many more interesting parts of stroke care with blood pressure lowering agents in ICH and intracerebral hemorrhage patients. Yeah, there are a lot of work that we need to look into. And time is brain and time is pre-hospital. So the answer will be to all questions that we need a better pre-hospital service, definitely.
And what a powerful message for us to take away. I mean, this has been such an incredible snapshot of a huge amount of work by you and your team. It's been so thought-provoking for me, and I'm sure it will be for many of the people listening to this podcast. Just the potential is amazing. So as we sort of bring this conversation to a close, are there any other key messages that you would leave us with from your whole journey with this? Is there any sort of key takeaways, and maybe anyone who's thinking of following in your footsteps? What advice might you give to people who are who now have got them thinking?
Never take no for an answer. And I think that my key message is for all paramedics and maybe paramedics leaders or staff that are involved in training, both paramedics and also students, we need to invest more into how we train, and we need to invest more into clinical skills and not get blindfolded by all these technical possibilities of imaging and biomarkers and so on, because I believe that the clinical skill is the way to go for better patient care, and training paramedics is absolutely the way to go.
I'm so inspired. Maren, thank you so much. It has been such a huge pleasure to talk to you. We'll post the links to the ParaNASPP project and the publications in our show notes for anyone who might be interested and find those useful. So just thank you so much for sharing with us all the work that you've done and for your time today.
Thank you so much. It's been a pleasure, and have a nice day.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.